you very much for your kind introduction. I'll be sharing my screen. Right, so the title of my presentation is about postpartum hemorrhage. An additional title I've given to this is A Race Against Time. And during the presentation, I'll also be making a reference why time is so important when it comes to postpartum hemorrhage. Both at managing postpartum hemorrhage as an emergency that it is, but also how it is an emergency for WHO and the improvements we really want to see in postpartum hemorrhage and the burden of postpartum hemorrhage as it impacts maternal mortality. And there's a very good reason why postpartum hemorrhage is such a huge priority for WHO. Over the last few decades, we have enjoyed progress when it comes to maternal mortality. We have seen reduction across the world in the maternal mortality. But unfortunately, in the last 5 to 10 years, it looks like the progress that we have been seeing has now stagnated. And in fact, in the last few years, it's almost a flat line. And a flat line for something like this equals to death. And unfortunately, we will lose an additional 1 million mothers unless we see the progress that we were hoping for from the Sustainable Development Targets by 2030, that we wanted to drop maternal mortality at 70 over 100,000 live births. And when it comes to maternal mortality, postpartum hemorrhage is the top priority. It is the most common reason why mothers die, and it's also a very, very frequent complication. So many mothers will suffer from postpartum hemorrhage. Likely, most of them will survive, but unfortunately, still an unacceptably high number of them will pass away unless they are treated appropriately. So WHO has issued many recommendations when it comes to postpartum hemorrhage. It is a big priority for WHO, and it has issued perhaps the largest number of recommendations when it comes to postpartum hemorrhage in terms of how it's best to prevent it, diagnose it, and treat it. So I'll be summarizing some of these recommendations and some of the interventions that WHO recommends against, or for some of them that we still have insufficient evidence. And then I'll be highlighting 2 of our new recommendations when it comes to postpartum hemorrhage. So perhaps many of those are familiar to you, but perhaps the 2 new ones are the ones we'll be going through much more in detail and the evidence underpinning those new recommendations. So when it comes to the prevention of postpartum hemorrhage, you can see WHO has issued a big number of recommendations. So WHO recommends oxytocin for the prevention of BPH for all births. So that means every woman that gives birth needs to have an injection of oxytocin, either 10 international units IM or intravenous. And it also recommends that the intravenous administration should be done in preference to intramuscular administration when women already have an intravenous access. Carbetocin for the prevention of BPH is also recommended, 100 micrograms IM or IV, but in context where its cost is comparable to other effective uterotonics. Oral misoprostol, 400 micrograms or 600 micrograms oral is also recommended for the prevention of BPH. And ergometrin, 200 micrograms IM or IV is also recommended for the prevention of BPH, where hypertensive disorders can be safely excluded. Now, the combination of oxytocin and ergometrin, where is that available? It's 5 units and 500 micrograms of ergometrin. Again, it's recommended with a similar contraindication as the ergometrin, so you need to be able to exclude hypertensive disorders. The injectable prostaglandins, carboprost or suprastone, are not recommended for the prevention of postpartum hemorrhage. And this is because of a high number of side effects with these medications and fairly high cost. Now, as you can see, you have several uterotonics that are recommended. So in the context where you have multiple uterotonics available, oxytocin is the recommended uterotonic of choice. So if you do have, for example, access to all of them, you would still use oxytocin as the single uterotonic of choice for the prevention of PPH. And the other uterotonics, you will use them where oxytocin is not available or its quality cannot be guaranteed. Now, for settings with community health workers or lay health workers, the use of oral misoprostol is recommended, not of any other injectable uterotonics. And we also recommend the antenatal distribution of misoprostol for self-administration in certain settings where there is existing targeted monitoring and evaluation. Still staying on prevention, the controlled cord traction by skilled health professionals for vaginal births is recommended for the removal of placenta. It is not recommended if it's done by non-skilled health professionals. And also sustained uterine massage for the prevention of postpartum hemorrhage for women that already had oxytocin is not recommended. So sustained is different from just uterine tone assessment. Sustained uterine massage here means ongoing massage as soon as the woman has given birth for a great amount of time for the prevention of PPH. For cesarean sections, again, oxytocin, intravenous or intramuscular, is the uterotonic drug of choice for the prevention of PPH. And controlled cord traction for the removal of placenta is also recommended for cesarean section. So the same interventions are recommended for both vaginal births and cesarean sections. So for all births, late cord clamping should be done. So that's at least 1 minute after delivery of the baby. And early cord clamping, so clamping the cord of the baby less than 1 minute after birth, is not recommended as an intervention to reduce postpartum hemorrhage because it's not effective and it's very beneficial for the baby to have late cord clamping. So unless you have to resuscitate the baby, late cord clamping is the recommended intervention here. Okay, so moving on to diagnosis. So there are 2 recommendations for diagnosis. One is recommended and one has insufficient evidence. But the one that had insufficient evidence, I'll be presenting our updated recommendation now because we have had new evidence that has now changed that recommendation. So recommendation 19 is that postpartum abdominal uterine tone assessment for the diagnosis of uterine atony is recommended. So as soon as the woman has given birth, uterine tone assessments should be regularly checked to diagnose atony and by extension postpartum hemorrhage. The next recommendation was about measurement of blood loss. And at the time, we had insufficient evidence for WHO to recommend for the measurement or against it. So it had called for additional research evidence. Now we do have that additional research evidence, and we have issued a new recommendation on that I'll be going through later. For the treatment of postpartum hemorrhage, intravenous oxytocin as the first-line treatment for postpartum hemorrhage is recommended. Ergometrin, the oxytocin, ergometrin fixed-dose combination of prostaglandin drugs like sublingual misoprostol when oxytocin is unavailable, or if the bleeding does not respond to oxytocin, they're all recommended. But intravenous oxytocin is the first treatment, with the additional uterotonics being second-line treatments. Intravenous tranexamic acid, that's 1 gram over 10 minutes within 3 hours of giving birth, in addition to standard care for women with PPH, is recommended. So again, that's part of the first response for postpartum hemorrhage together with oxytocin. Oxytocin combination with controlled cord traction for retained placenta are also recommended. And ergometrin for the management of retained placenta is not recommended. And the same thing is for dinoprostone or sulprostone, the management of retained placenta. So these two uterotonics should be avoided. They induce a clamping of the uterus and restriction of the cervix that is not beneficial for removing the placenta. So WHO is recommending against these two uterotonics. There's also insufficient evidence about the umbilical vein injection of oxytocin for the retained placenta. So again, this should not be done outside the context of research. For retained placenta, a single dose of antibiotics, ampicillin or first-generation cephalosporin is recommended. Now, moving on to the refractory postpartum hemorrhage. So these are also treatment recommendations. And uterine massage for the treatment of PPH is recommended. So, so this is not necessarily for refractory, this is for all PPHs. Uterine massage should be done together with oxytocin and tranexamic acid. Now, bimanual uterine compression as a temporizing measure is recommended until appropriate care is available for the postpartum hemorrhage. So bimanual uterine compression is not necessarily for all PPHs, but for those that did not respond to the initial measures, and if you need to buy yourself time until appropriate care is available. The same thing is also for the external aortic compression, which is recommended for the same reason, until appropriate care is available for postpartum hemorrhage. And both are for tackling with atomy. Uterine balloon tamponade for the treatment of postpartum hemorrhage is recommended, but in the context where the first-line treatments like oxytocin, tranexamic acid, massage, and so on have not been effective. Non-pneumatic anti-shock garment, again as a temporizing measure until appropriate care is available, is recommended. Uterine packing, on the other hand, is not recommended for the treatment of postpartum hemorrhage. Uterine embolization, where all the other interventions have failed and resources are available, is recommended. And then finally, surgical interventions if bleeding does not stop despite treatment with uterotonics and other conservative interventions like massage or tamponade, then surgery is recommended at this stage. Staying for the treatment of postpartum hemorrhage, the use of crystalloids in preference to colloids for the initial intravenous fluid resuscitation of women with PPH is recommended. So for all women with PPH, there are 4 recommendations. So they should all have oxytocin, they should all have tranexamic acid, they should all have massage, and they should all have isotonic crystalloids. These are for all women with PPH. The other recommendations are for those who have not responded to the first response treatments. Recombinant factor 7 activated there's insufficient evidence for this intervention, so it should not be practiced outside the context of research. And in terms of health systems, WHO recommends that health facilities should have formal protocols for the prevention and treatment of postpartum hemorrhage. And this formal protocol should also include referral pathways for women at a higher level of care. Simulations of PPH treatment, both for pre-service and in-service training programs, are recommended. And finally, the monitoring of the use of uterotonics after birth for the prevention of PPH as a process indicator for programmatic evaluation. So that means auditing how many women are receiving uterotonics routinely for the prevention of PPH. So these were all the recommendations. Now, WHO appreciates that implementation of all these recommendations can be challenging. And there are many reasons why some of these recommendations may not find their way all the way to benefiting women. And in a recent summit around postpartum hemorrhage and what do we need to do to get all the effective interventions implemented in the countries that are most in need, stakeholders from 50 plus countries and 140 stakeholders in total, including 20 ministries of health of the high burden countries, prioritized, what are the biggest implementation bottlenecks or barriers that we really need to act upon if we want to see these recommendations implemented. Now, those are the full list of potential implementation barriers that are spanning the national context, programs and investments, commodities, and service delivery. And the stakeholder group at the PPH Summit prioritized 5 of those that are perhaps the most important to making sure that these effective interventions are benefiting women. And the first one was national health policy and leadership. So the countries, they do need to have their own national targets for tracking progress of how they're getting these interventions implemented and if they're seeing improvement in outcomes. And another aspect of leadership is that stakeholders were flagging is that perhaps there's lack of mechanisms for guideline translation. So WHO issues many recommendations, but nevertheless, some of those don't find their way into national guidelines and policies, so they can be used by the providers. Second was the equity and access to care. And that was a huge problem, especially for countries that have user fees, so they charge for care. And that was affecting the most vulnerable and marginalized groups that perhaps cannot afford paying for healthcare. And that meant that they have to give birth outside facilities, and the outcomes were worse for these groups. And in some countries and some areas, perhaps the private sector is the only sector that it's available, and unless they engage in being more inclusive, again, the outcomes for the majority of the community may be poor. Third one was the women's rights and social status. So it was felt that many women are not aware of the risks of postpartum hemorrhage, of how common it is, and what kind of facility can really cater for the good diagnosis, for the prevention, diagnosis, and treatment of postpartum hemorrhage. And at some communities, there was very little choice of women around pregnancy and childbirth. Fourth bottleneck was the staffing, training, and supervision of providers. And here meant that many settings felt that they were understaffed to implement a lot of these recommendations, or they did not have sufficient training, or perhaps follow through, perhaps from the initial training, follow through of supervision of healthcare providers to build on skills, especially for interventions that are not so easy to learn, like, for example, uterine tamponade or surgery. And relevant to that was also that there was very limited scope for task sharing. So some of these recommended interventions, there was a small number of doctors available that they can implement them, but the midwives were not feeling empowered enough to implement them, and they often were the first responders when it comes to the diagnosis and first response treatment of postpartum hemorrhage. And lastly, with availability and supply chain for commodities. So often the commodities are not available, or there's a stock out, or they were of poor quality. So WHO is rallying with the stakeholders to try and address some of these bottlenecks for the most high burden countries. And then in terms of advocacy, so it's not just about overcoming some of these barriers that are perhaps WHO has limited ability to overcome some of those, but some advocacy can help also within the country to lift some of these barriers. And all stakeholders, they do have a role to play when it comes to advocacy and improving implementation of what works. And apart from women, that they need to be aware of what are the risks and what is the standard of care they should be expecting when it comes to postpartum hemorrhage and in general complications of childbirth. Healthcare workers like yourselves, perhaps, they need to be engaging their national societies, and they need to be demanding for the new guidelines to include the full range of WHO recommendations, including the most recent ones. And they should also be demanding for on-the-job and continued trainings and supervision. And then the Ministry of Health and Government has a role to play in terms of monitoring, in terms of collecting data on the burden and implementation of these recommendations, ensuring good quality medicines and a good supply of them, and try to collaborate either from global and national level to ensure all the guidelines are being implemented. And this may also include a multi-sectoral engagement in country. International community has a role to play, and the summit was a way of bringing this fragmented ecosystem in being better coordinated and rejuvenating some of the funding mechanisms, so we can see progress on postpartum hemorrhage and, by extension, reduction in maternal mortality. Okay, so these are the initiatives that are going on at a global level. Here, I just want to present to you the underpinning evidence that led WHO to 2 new recommendations around postpartum hemorrhage. And the reason for the 2 new recommendations was this landmark trial called the EMOTIVE trial. And I'll be presenting, why this trial was important, how it was done, and what were the findings that then impacted WHO recommendations. So before the trial was done, it was conceptualized that there are 3 main problems when it comes to postpartum hemorrhage. There seems to be a missed or delayed diagnosis of postpartum hemorrhage. So many women with postpartum hemorrhage, they never receive treatment, or when they receive it, it's actually already late. So they've lost a big amount of blood. And when it gets diagnosed postpartum hemorrhage, it means that not everyone gets all the effective interventions. So some of them are not used at all, or some of them are used quite late. And again, when some of these treatments are being used, there seems to be also a delay in escalating care. So if something doesn't work, there seems to be quite a lot of delay on escalating to more effective interventions that perhaps are more invasive, but they can save the woman's life. And starting with the misdiagnosis. The problem we have with misdiagnosis is that we're relying on visual estimation. So here you can see an experiment that we often use in our trainings, where we ask providers, doctors and midwives, to estimate how much blood loss there is in these buckets. And the guess, it varies so much. Perhaps you can see some of the writing on the right, that for these estimates, they can vary from a few liters of blood to a few mLs. And it's almost a guesswork rather than an actual estimation. And this is because we're relying on the visual estimation, which we know it's inaccurate. And then we have data to support that. So what we are saying is that the visual estimation being inaccurate, it's not something only in theory, but we're also seeing in our own studies that providers seem to be missing a very high number of postpartum hemorrhages. So this is a trial done on 30,000 women, and you can see on the horizontal axis the blood loss that women had in 100 ml increments. And on the vertical axis, you can see how many of them received uterotonics. So it means that there was a diagnosis of postpartum hemorrhage, and then they had treatment. And in the first mark, which is 500 mL, that's the conventional sort of definition for postpartum hemorrhage. You would expect, you would want, ideally, all women to have received treatment at that point. But only a quarter of women actually receive treatment within a trial. So we expect even within routine practice, that number will probably be even lower. But even when you go to 1 liter of blood, you will see that still 30% of women have not yet received treatment. So, the provider have not realized that these women had a postpartum hemorrhage. And if you look across for all women, you will see that almost 50% of women are not routinely diagnosed with postpartum hemorrhage, having lost more than 500 mLs. And again, so we're missing half of the cases here. So this is not a good diagnostic performance. And when it comes to improving diagnosis, and we're saying we're missing blood loss, so there are many ways we have thought of how we can improve diagnosis in terms of collecting the blood, so we can estimate a little bit better of how much has been lost. And there are various tools that we can collect the blood. Perhaps the one that's most promising was a drape that is transparent, and the provider can see exactly how much blood is in the drape because it's also calibrated. So it has lines telling them whether it's 200 mLs, 300 mLs, 400 mLs. And there are, because it goes under the women, there are no spillages, so it collects all the blood. And now going to the missed or delayed treatments, so the second challenge. And the challenge comes from the fact that providers usually in their routine practice, they don't use all the effective interventions that are recommended. So as I was saying earlier, WHO recommends that all women with postpartum hemorrhage should have massage. And all women with postpartum hemorrhage should have oxytocin. And again, all should have tranexamic acid and crystalloids and so on. But what happens in practice is that if a woman is bleeding excessively, someone may try the massage first and wait for 5-10 minutes and see if that works before they administer oxytocin. And again, wait for another 10 to 15 minutes to see if the oxytocin works before they administer tranexamic acid. And then wait to see what happens. And perhaps only if she's hypotensive, they may use some crystalloids and so on. But this is not how WHO recommends these interventions. It does recommend that all women with postpartum hemorrhage should have all these effective interventions: the oxytocin, the tranexamic acid, the fluids, the massage, and of course an examination to see where the woman is bleeding from and try to stop that bleeding. And then we should be very clear about when our first response has not succeeded. And perhaps, it would be helpful to have some criteria of when do we need to escalate to refractory care. So WHO recommends many interventions for refractory PPH, but we need to be clear when this should now be started. So this is how current practice works. There's a time that takes to diagnose, then we go one by one the first response treatments, and then there's a further assessment before we escalate to refractory treatment. And what Imogen was suggesting to do, we should really cut down how long it takes us to diagnose postpartum hemorrhage. So we diagnose all of them, and we diagnose all of them early. So when they have lost 500 mLs, or there are any other abnormal signs. And when we treat them, we don't use one intervention, wait for some time, and then use the other one. We use them, all of them together at the same time or in very quick succession without waiting to see if the one has been effective. We give all of them before we assess if they have been effective. And then as we are assessing if they have been effective, we have clear criteria so we can escalate care to the refractory interventions. So this is the emotive interventions, so the early detection and bundle first response for treatment. Now, very briefly of how the trial was done. So it was done in 80 hospitals. They all started receiving usual care initially, and then they were randomized. So 40 continued using usual care. Meanwhile, 40 transitioned into the new protocol. And at the same time, we're also trying different ways of implementing the new protocol so we can be more successful. And this was the design of the study. So they included all women having vaginal birth in study facilities. The intervention was the early detection of PPH and the treatment bundle, and that was compared with the usual care. And the outcome of interest was the severe postpartum hemorrhage or laparotomy for bleeding or maternal death from bleeding. It was done in 4 countries in 80 hospitals, and these were secondary level hospitals. So they had around 1,000 to 5,000 births a year, and they were able to provide comprehensive obstetric care, so including surgery for postpartum hemorrhage. When it came to the early detection, we said that the drape was used. So it was a calibrated drape for the blood loss collection, and it had the trigger lines at 300 and 500 mLs. So at 300 mLs was a yellow line, and at 500 mLs was a red line. And doctors and midwives were asked to also do observations, so to check the drape every 15 minutes, check the flow of the blood and the uterine tone every 15 minutes for the first hour, so 4 checks. And there was a blood loss monitoring chart that they could document these observations. Blood pressure and pulse was done in the first set of observations, and then it was only repeated if it was abnormal or if the woman started bleeding. And we asked doctors and midwives that they should treat anyone who has blood loss of 500 mL or more, so that definition of postpartum hemorrhage, or when they think by the clinical judgment that perhaps the woman is anemic, or they're worried about the flow of blood and it's likely to be a postpartum hemorrhage very soon, or that she has lost 300 mL already and she seems to have some other abnormal signs, so perhaps it's tachycardic or hypotensive and so on, again suggestive of being already bleeding excessively. And for women that are anemic, they may get quite unwell even before they reach the 500 mL threshold. And when they decide to trigger treatment, they shouldn't just do one thing, they should do the whole bundle of treatments. So they should massage the uterus until it was protracted, or at least for 1 minute. They should give oxytocin, and they should give 10 units of intravenous oxytocin as an injection or diluted in crystalloid if they preferred over 10 minutes. And then also give a maintenance dose of 20 units intravenous oxytocin diluted in 1,000 ml of saline over 4 hours. And that was also including the crystalloids that were recommended by WHO. But we know that oxytocin is quite a short-acting medicine for someone who has a postpartum hemorrhage. An ongoing maintenance dose of oxytocin is frequently used, and it's likely to be effective. Tranexamic acid, 1 gram as intravenous injection, either as injection or diluted again in crystalloid over 10 minutes. And the IV fluids was already given as part of the oxytocin. And if they had to give more, they need to make an assessment if they're clinically indicated for resuscitation, and if so, they may require a second intravenous access. For the examination and escalation, they had to ensure the bladder is empty. They had to evacuate clothes, check for tears, and placenta for completeness. So check for the 4 keys for hemorrhage, for the tone, tissue, trauma, and thrombin, so the clotting. And then if they, at the same time, while they're examining, they should escalate if they felt that the bleeding is not stopping with the first response, or they're unable to identify the source of bleeding, or they identify the source of bleeding, but they're unable to manage it. So, for example, for a very complicated tear that they cannot suture by themselves. And this was compared with the usual care. So usual care is what people do, and what people do is they rely on visual estimation. They rely on using the recommended intervention sequentially. So they may use some of them, but not all of them consistently, as it was happening in the EMOTI protocol. And the outcomes we wanted to assess was the severe hemorrhage, so blood loss of 1,000 ml or more, laparotomy, or maternal death from bleeding. And we wanted to reduce these outcomes from 4% down to 3%. And we thought we would reduce those outcomes by improving the diagnosis and also compliance with the bundle approach. So that was a very large study. There was over 200,000 women giving birth in that study across the 4 countries. And we had a very high percentage for completed data. So very large study and quite valid in terms of the data quality. And I'm going to the results of what we found. So the hospitals were fairly balanced in terms of the number of births, in terms of complexity of cases that they managed. So they were quite comparable. And the result that we found was even better than we expected. So we're hoping for a reduction from 4% down to 3%, but we actually found a reduction of 60%. So from 4.3% in the usual care for the primary outcome down to 1.6%. And that was, of course, statistically significant. And here you can see in graphical sort of month by month what happened with the improvement and the training and the reinforcement of this new approach. And that severe bleeding started dropping quite quickly after the trainings and the implementation approaches, and then just continued dropping month after month. So as people were improving and learning how to do things more efficiently and being very economical with time, so they want to save time for diagnosis and treatment, because it doesn't matter when somebody is actively bleeding, they were getting better and better. So this is the green, and you can show the drop, it's happening month after month during the study. And in fact, at the end of the study, the reduction was over 80%. And in terms of what else did we observe during this trial is that the diagnosis, as we were hoping, improved. So the usual care, what we knew before the study is that they miss around 50% of postpartum hemorrhages. And that was the case also in this study. So they were still missing 50% of the cases. But with the emotive approach, now they were not missing that many. They were only missing around 6 to 7%. So a huge improvement there. And in terms of complying with all recommended interventions, so only 20% of women were getting all the interventions recommended by WHO before, and after with a bundle, they were getting over 90% of them. Other outcomes also improved, so the postpartum hemorrhage diagnosis improved, the severe postpartum hemorrhage, mortality, all-cause maternal mortality, blood transfusion for bleeding was cut almost by 30%, and blood loss as a continuous outcome. So all sort of blood loss related outcomes, they've all improved. And it seems to have worked in all countries. So they all had the positive results, some of them more effective than others, but nevertheless effective in all of them. And drilling down a little bit more about why it was so effective. As we said, usual care were missing half of the PPHs, and you can see a very steep improvement within emotive. From the previous graph, at 500%, at 500 mLs, only a quarter had received treatment. With the usual care, now almost 80 or 90% women have received treatment. So people were acting earlier, and they were acting much more efficiently. So they were not now waiting to see if one thing works, they were giving everything at once. And that was the case in all countries. So they all improved quite a lot, and they all seen the benefits of that time efficiency. And we're also able to document the time efficiency, the time of treatment. So, for example, was cut by 10 minutes. So how long it takes in the usual care to give all the effective interventions was 23 minutes, and was taking only 13 minutes in emotive to do it. And it was even a bigger improvement when it came to diagnosis, because the biggest delays in the usual care group is that people were not even initiating treatment. There's a health economic analysis that is just published that shows that emotive approach was cost effective. And now with the price of the drape being less than $1, I think the latest estimates I've heard was around 60 cents of the drape that was used, and the price keeps coming down as new innovations are coming up. It's now cost saving. So actually implementing e-motive in the hospital not only does not involve an additional cost, it actually saves money year after year. And that's because you're reducing blood transfusion, surgeries, and so on that are very costly, apart from obviously saving lives, which is priceless. So hence WHO has now considered the evidence and has issued new recommendations that I'll be describing in a minute. Many studies are starting also in different settings, including in Asia, in terms of how to implement this approach in their setting, and some of these are ongoing. WHO has already considered the evidence, has issued recommendations, and that is being disseminated and implemented. And these are the new recommendations. The WHO has issued two recommendations. One is about the blood loss estimation, and one is about the treatment bundle. So for all women giving birth, now WHO recommends that routine objective measurement of blood loss should be done. So we appreciate that the visual estimation is inaccurate. We appreciate that e-motive study is perhaps the biggest study out there that using a method for the routine objective measurement of blood loss. And for that study was used a calibrated drape. So just to be mindful that there are other devices available, but just to be mindful that the drape is perhaps where we have most experience with. But other devices, and especially reusable devices, can also be used as long as they achieve the same purpose. So being able to collect all the blood and give that feedback to the providers of how much blood is there, so they can act early in the process. And this blood loss measurement is critical in the first few hours. So in the study, the blood loss measurement was happening in the first hour, and then it was stopped, unless the woman was bleeding, so then it continued for 1 more hour. And measuring the blood loss, it's not enough on its own. Obviously, measuring will not do anything unless you can act on what you're measuring. So you need to have very clear criteria of when you're going to be starting the treatment, whether it's just the definition of postpartum hemorrhage at 500 mL, or with additional criteria that were used in the e-motive study, especially if you are catering for a population that is with a high prevalence of anemia. You may want to consider additional criteria with abnormal vital signs and so on. And in terms of the drape, so the drape that was used in this study was plastic and single-use, which is not ideal. So there are versions of it that are compostable or biodegradable or reusable. So just to be mindful that if you are planning to implement such an approach, you may want to look at those solutions as well. Secondly, is about the standardized and timely approach to the treatment of PPH. So together with objective assessment of blood loss, you should also have a treatment bundle. And what that means here is that you should use all the effective interventions that we know and they're recommended. So if you want this to work effectively, people need to do all this at once. And ideally should be done with a short amount of time. So in the e-motive study, we're targeting that they're all being initiated within the first 15 minutes, so we can get major benefits. And on themselves, they may not work instantly, so you may need some implementation strategies to achieve these benefits. So some audits and some trainings to make sure people understand what they have to do, what is different from what they were doing before, and monitoring some of these indicators. Are they diagnosing all PPHs? Are they treating them all with a bundle and so on, just to reinforce these new recommendations. So we have published this paper and the new recommendations, and we also published about the implementation bottlenecks and how we can overcome some of those when it comes to postpartum hemorrhage in a detailed roadmap of, what do we need to do at the global level or regional level or country level, if you want to see progress in reducing the burden of postpartum hemorrhage and maternal mortality. And now we have also published the two new recommendations on the objective measurement of blood loss and treatment bundle. Yeah, thank you very much. I'll stop here and happy to answer any questions.